Hello everyone, Maria Trusa and
Gina Capelli.
oh, she's quiet today.
Well, give me
What happened?
Give me I'm coming off of 5 days with her.
5 days of vacation. Reflect and reset with Maria and Gina. And I'm sorry that we are a little late today, but we have our special guest who duty calls. He is our medical director and our primary care doctor, Dr. Gary Midelton.
Oh, she just took my part. And
Anyway.
And also, I'd just like to say really fast,
Yes.
to all of my fans out there in the DR, hi everybody, I found out that I'm actually famous in the Dominican Republic. Can you imagine? They knew me because of this show.
It is.
Really? Yeah.
It is true. It was. We were like blown
Yes,
away
we're
with.
blown away.
Oh, Gina.
Yes, I know you.
We see
Just
you.
just wanted to do a shout out to all my friends, all my fans out there. So,
Anyway, so
yeah.
going back to seriousness,
Yeah.
so let's tell us about what is our show about today?
Well, we're going to talk to Dr. Midelton, our very own medical director and primary care doctor. And we're going to talk about preventive medicine. We're going to answer some questions that people have had of, when to do certain things, when to sign up with a primary care physician, what happens what difficulties the doctor faces when you're not compliant to what he's trying to tell you to do to keep yourself healthy. And then we're going to touch base on a couple other questions that people have.
So, Dr. Midelton, how are you today?
I'm fine, thank you.
Well, thanks for joining us. He was actually seeing patients today and had a few emergencies, so we ran a little late. But we want to ask you, why is it important to have a primary care doctor?
Well, the primary care doctor, we're mostly responsible for keeping people healthy. Okay, so if you get your checkups every year, and for any chronic conditions, if you're doing good follow-up, we don't just yell at the patients. It's not really the point. We try to keep illnesses in check so that they don't advance.
Yeah.
And the problem with what we do is everyone says they feel fine, so they stop taking medications.
Meanwhile, it's the medication that's making them feel fine.
No, not a lot of times. I'd like to say, that the medication makes them feel fine, but usually, in most cases, it doesn't.
Okay.
Because a lot of the illnesses that we treat, they're asymptomatic. They don't have any symptoms until it's too late.
Right.
So once it's too late, if the first time you know that you had high blood pressure is because you show up in the emergency room with a stroke, well, that's too late. That is an end catastrophic event that we try to prevent, years ahead of time from ever happening. So what we try to do is reduce, and by doing the blood work once a year, even in someone who's healthy, what we really, and telling people not to smoke, telling people to eat properly, telling people to exercise, it's all about reducing their risk of catastrophic events.
Okay.
So I know that patients when they're taking medication. And about 2 weeks ago, we had the chance to work together because I was the medical assistant. And one thing that I noticed is that patients resist that they have to come and be checked every 3 months when they're on all these medications.
Right.
I remember there was a patient that had like 7 medications, and he was complaining that, you want me to come because you want the money from the visit. Talk to us about that.
Well, first of all, the standard of care is usually for chronic conditions about every 3 months. Part of the reason, number one, you want to touch base with the patient. There certainly is evidence that if we talk to the patients, that we keep on top of them, they know that they're going to see us, that it does sort of, it can help them stick to the plan, keep taking their medications, stick to their diet, because they know they're going to come in and, like I said, we don't want to yell at people. We usually don't, but they know they're going to be asked. So
accountability.
Yeah.
Exactly. The other reason is with a lot of the illnesses, high blood pressure, diabetes, we're going to see things in the blood work way before anybody has a symptom of anything, and a lot of that is because it is also from the medications that we give. So you can get a lot of electrolyte disorders with most of the blood pressure medications. So we don't want someone showing up in the emergency room with a seizure because their sodium was very, very low, or their potassium was very, very high. We have to monitor these things, and we have to make sure that the medications are not doing them any harm. So that's part of the reason. And it doesn't mean we're going to draw blood every single visit, but most of the time we do.
We need to, yeah.
Because there's a lot of drug-drug interactions that we're trying to manage and control and make sure that nothing is happening.
Right.
That is a beautiful, clear explanation. And I was amazed of how many patients complained. So we got to figure out, this is a great media to be able to explain to people what is the reasoning, because they feel they should be on these medications, and if they're feeling fine, they don't need to come. But like you said, there are things that are happening that they would not have symptoms. So it is important to come and I know.
And when do you suggest that somebody get a primary care doctor and start a baseline?
Is there an age?
Is there an age? I know you switched from 21, I think, for pediatrics to
18.
But
some pediatricians will see their patients until a little bit later. But listen, when you're, for me, it was when you drive to your pediatrician, I think that's time to get an internist.
Right.
That's my opinion. Probably around 18 is, but there are some pediatricians that will keep their patients until 21.
And then you'll do the physicals and get the baseline of where they are, and weight, BMI, and all that.
Yeah, and it's usually once a year.
Once a year for somebody of that age, until you start seeing something.
Yeah, then of course it becomes, their visits will be more frequent, and anything that comes up in between that they may complain of. But physicals have always been every year.
Mm-hmm.
And that is for everyone.
Yeah.
And if you think about it with the kids, like you're taking them every year, so really a physical is something that you should do for life every year.
Every year, right.
I can't say, but and I don't do pediatrics, so I don't know that when they're kids, there is a period of time I think that they may not go for a year or 2 or 3. Because mostly they end up following up with the pediatrician when they need the vaccine.
Immunization.
So they're scheduled well visits, and they usually do it with the vaccines, and then there is a period of time where maybe in their adolescent years they may not be seeing the pediatrician every year, but it's still a good idea to follow up.
I mean, if you think about it, once a year, take an hour to 2 hours of you going in just to make sure that you're okay. I mean, it's not a lot.
No.
If you think about it. My daughter is 11 years old, and I actually take her to the pediatrician every year.
Yeah.
So, because they also ask for the immunization records,
Right.
and then the physical exam that they need to do. So preventive medicine, we are a country that focuses a lot on preventive medicine. And I say we are a country because I know that I come from the Dominican Republic. And the focus on preventive medicine, I think, is something that we are learning to do to the level that we're doing here. But it's not, people don't go as often as they come here. But this is the major focus for the United States. And it is a major problem, right? Because we are the problems of preventive medicine, that people don't really go to the doctor as much as they should. It is something that is very real, right?
Yeah, and of course it goes by age, it goes by family history and risk factors of, as you get older, we do more and more things to prevent. Really, we start cancer screenings. The higher in age that we get, so all that stuff becomes very, very important. So because when you find something, and it happens, I mean, we'll send people for colonoscopy. There's a woman I can think of off the top of my head, and they found a small polyp because we sent her for a screening colon cancer. She has no cancer in her family. She has a tiny polyp of cancer, and she's cured. They just snipped it. That's pretty much all they had to do. But imagine if you wait until that becomes a huge mass, and then it goes into your lymph nodes, and then it spreads to other organs. Then it's very difficult to treat. It's much more difficult to treat as far as what kind of, you got to do chemotherapy, big surgeries. I mean, all she has to do, now she'll have to have colonoscopies much more frequently, but I'd prefer that any day.
Yeah, right. That's
To having my intestines cut out, having a diagnosis of metastatic cancer, having to go through chemotherapy, I mean, all the hours and days that you miss from your family, from work. I mean, that's not an easy road.
That is life altering.
And it happens wherever, you catch people that.
And and what we find is that, with our patients here, that sometimes they just don't want to take some of these tests home. Like even the iPros and but everything, the iPros, the ABIs that we do, they don't want to deal with it. Meanwhile, you're like, why? I mean, we're trying to set you on the course to be healthy for your family, but they argue with you and they don't want to take those tests, and it's almost like if you don't know, it's better not to know.
Yeah, well, that's pretty common, and not just with necessarily our population. A lot of people, there's something in the back of their head that they prefer not to know, and it'll go away. And of course, it won't. It doesn't. So and then things can gradually get worse. So but yeah, and some people look at it as, and it's not. But they look at it as a punishment. And it just is not. It absolutely is not. Yeah. So all the things that we do is to try to, make someone live longer with less problems.
Do you find? We know from our data that men do not go to the doctor as much.
No, but they show up in the hospitals and the clinics all the time. From the data from the health links, we'll get on that subject.
But going back to that, so how can we make a difference? How can we encourage men to come to the doctor?
For preventative.
Well, I think to make men come, when I tell them that some of these illnesses can affect their sex life, they come in more regularly, or they'll listen to me, but. It's not exactly a joke.
No, it makes sense, because if you're taking high blood pressure medication, some of them could affect, right?
Yes, well, and not taking it can affect. That's one of the first things to go.
Interesting.
So, and then
So if somebody has high blood pressure, there's a possibility that they're
the erectile dysfunction. It's a risk factor. It's a risk factor. Smoking, high cholesterol, diabetes, and high blood pressure. Those are the 4 main risk factors for erectile dysfunction. So sometimes the men will listen to me when I tell them that these things can cause that.
Yeah. So. In prostate cancer, so there's prostate screening. What is the age for prostate screening?
That is something that is, I want to say it's in flux. I'm still doing it pretty much at the age of 50. I think most doctors are, but a lot of these screenings, the name escapes me, the American Preventive Task Force Committee will come up, and they come out with different guidelines and variously, and I don't always read who's given what guideline. There's a bunch of different organizations. I actually just read last week that they want to begin mammograms screening not at age 40, but at age 50, and even then it should be every 2 years, not every. Yeah. Now I can't remember. I'm trying to remember which committee came out with this. There's more than one committee. There's a bunch of committees that come out. They're always competing for different guidelines as to who should be listened to. So a lot of these are in flux. Like, years ago you get a pap smear every year.
Right.
And now it's not, the trend is that's not necessarily true anymore. So it can be, once every 3 years, and it's not my field, so it's mostly what I hear the patients telling me. I've had patients come back and tell me, once every 3 years, once every 4 years. And that's like if they've had no problems, I think a few years in a row consecutively, given age, of course, and risk factors and family history. Same, and mammograms also. I think most gynecologists and obstetricians are still sending every year. I'm still sending every year unless someone comes to me and says that their gynecologist had recommended to go every 2 years and they don't have a family history of breast cancer. So prostate cancer is one of those things. There is a screening test. There seems to be a push to either not do it or to wait until age 60 because the outcome appears to be either the same or they just end up doing more tests that can cause harm. So it does warrant a discussion with the patient. Now, if someone says, "Yeah, my dad, died at age 50 of prostate cancer," you're not going to wait on that person any more than you should, or any more than you have to. You'll be doing screenings actually probably earlier, but there is a push to starting to do those a little bit later in life. But
That's the blood test? Or
yeah, that's the blood test. The last time I checked, the recommendation and all this stuff, it's always in flux. It's always changing what their recommendation is. And they recommend sitting down, having a discussion with the patient, and doing a blood test. And if the blood test comes up, that it's high or elevated, then you can, you would do the digital exam, the rectal exam. But they no longer recommend doing it together. So that was a change from a few years ago. So it's always changing. It's always changing what they're saying.
Is there a reason why they would not enforce it to go sooner? I mean,
because they end up.
I feel like everybody we know is coming down has cancer. Like there's so many more young people with breast cancer.
They end up with high numbers of what the PSA is, but it's not. You have to diagnose it by a biopsy. So then the question is who gets biopsy.
Yeah.
So the PSA alone doesn't always give the whole story.
Yes.
So there's a lot of complaints that. Yes, it may be. Yes, it could just be elevated because it's elevated. There's other conditions that can cause it to be elevated falsely. People end up getting biopsy, and then it depends. And I'm not an expert on treating prostate cancer. It depends what stage you're in. A lot of times, even if you can have a low-grade early prostate cancer, they may do nothing for many, many years before they actually start to treat it aggressively. So then you end up in the pool, but you're not really getting necessarily any kind of treatment at that time.
So, I'll tell you the story about my brother. My older brother ended up going to the doctor because he was having chest pain while he was doing, there was a snowstorm and he was cleaning, the snow. So the doctor said, "When was your last time that you had a rectal exam?" And he said 2 years. And he said, "You really should have one." And he did a rectal exam and he said, I don't like how it feels. It just, I'm not sure what it is, but his PSA was a little elevated, so I ended up going with him to the urologist. And to make a long story short, he ended up having biopsy. He had 13 biopsies that were taken that day. My brother had the beginning of a cancer that was a Gleason 9. It goes from 0 to 10, which is the level of how aggressive it is. And it was at the tip. It was beginning. He had his prostate removed, but that cancer would have destroyed him if he didn't have that test. I mean, right?
And there's no history.
No history.
Right.
So he had to have a prostate.
Yeah. And the PSA will be elevated, and of course, if anyone has any symptoms of anything, also, then you would automatically automatically.
Well,
do it.
what would be the symptoms? Is it just like a pain, or is it?
Yeah, we have a question, so,
So the question is if there's possible that prostate cancer with an extremely low PSA.
I'm not a urologist. I don't think that can happen. I don't think it can. And but if you felt anything when you do the digital exam, the problem is when I feel them, and I have felt one or two. I'm not a urologist. They probably feel them, prostate cancers all day long. They're when you can feel them, they're pretty big.
Yeah.
They're big. It's
yeah.
already, that's going to show up in a PSA. So,
Yeah.
but I don't know that you can have a prostate cancer with a low PSA.
can we talk about the fit test versus colonoscopy?
Yes.
Because I know a lot of people that might not have insurance, they'll say, I am not gonna be able to afford a colonoscopy, so could you talk about that?
So the FIT test, you can do it in place of, for colorectal screening. It doesn't replace a colonoscopy because they're different, but you can use it as a screening tool for colon cancer. One of the largest differences is that it's every year. You have to do it every year.
The fit test.
The FIT test is every year. Where a colonoscopy, if it's fine, you're good for 10. If they find like 1 or 2 polyps, I think you're good for 5 years. If they find 3 or more, you got to come back every 3 years. Of course, the gastroenterologist tells you when to follow up. But potentially, you could be good for 10 years if you do a colonoscopy and it's clean. The FIT test has to be done every year, but the benefit is that you do it in your house. You don't have to take the prep, and it's very simple. It's basically a test with your stool, with your poop. So you just have to. It comes in. You get the kit. You have to wrap your hand in plastic or get a plastic glove. You catch it. You get a brush. You scrape the poop. You open the card. You rub it. Paint it onto the card, close it, put it in the envelope, mails right to the laboratory, and then they send us the results. So it's looking for blood. It's a little different than what we do in the office.
With the quick one,
with the quick one, right?
Yeah.
And that detects blood, but this one it has to do with the quantity of blood.
I see.
So it is a bit different, even though it is looking for blood. But it has to do with the quantity of blood. It looks for a larger quantity for it to kick off.
And usually is that one of the signs is bleeding from the rectal?
Well,
rectum that
blood in the
would
stool,
be-
but we call it occult, which means it's blood that you can't see.
I see.
But you pick it up in these tests.
Okay.
They'll find it. They can find it chemically because it's when it first starts and there's a little bit of blood. You'll never see it.
Right.
You rarely will see
And if
it.
you do see it, then you.
Well, then
It's usually-
it could be from. That's not
It could be
right. It
hemorrhoids,
could be
yeah.
from that.
Yeah.
There's a few other things that can cause it if you see blood in the stool, but mostly for colon cancer screening, you can't see the blood in the stool that we're talking about.
I want to make sure we cover today the difference between going to the emergency room at the hospital versus the urgent care. Because that's a big question, and we have people that go to the emergency room that shouldn't be there.
Right.
So talk to us
And
about
actually,
that.
before you even answer that, what I found with my researching the data is that some of our patients from here, instead of just booking an appointment to come see you, they'll go to the emergency room or the emergency room clinics to get seen, and they'll go multiple times, but they're not following their care the way you'd be following their care. They're not their primary care. And it's one of the campaigns we're going to start to be able to let you guys know that you have to, come see your doctor. Don't just go to a random doctor, especially if you have issues that you're dealing with. So what's your feed on the differences? And
Well, first of all, going to the emergency room, number one, it's the most expensive way to get care. And and nothing against any emergency room doctors that may be listening. They do seem to do an enormous amount of testing that, they don't know what's coming in. So, I don't begrudge them for doing it, of course. But we don't usually do that kind of testing all the time in urgent care. If someone came in and we thought they needed to go to the emergency room, and we do send people to the ER all the time because we think they need that higher level of care. But most of the time, that our patients end up going to the ER for, they just didn't need to go.
Right.
They didn't need to go. I had someone today that went there because they had nausea and vomiting. That was it. And it had been going on for a long time. It's not even that it was like an acute issue. He just decided one day he was sick of all the nausea and vomiting and went to the ER. I said, what do they do for you? He says, nothing. I mean, I'm not surprised. I mean, the ER and I think I can speak for them when I say this. They want life and death emergent. That's what they do. That's what they're trained for. Life and death. Right. They don't want to be dealing with that. You have a cold.
You need an IV because you're dehydrated.
Right.
You know, this is something that we do here.
We can't. See, now some of those things overlap because they would do that there, and of course we can do that here as well.
But if you do it in the emergency room in the hospital, it's going to cost you so much more.
Yes.
Even the insurance company. So whether you have insurance or not, with the insurance, you're going to pay a higher deductible.
Yes.
When you walk into an emergency room at the hospital.
Even if you don't have a deductible, the co-pays are usually $500 just to go into the emergency room.
I mean, most insurance company, they have a cost to going to the emergency room in the hospital. There's a lot higher than going into walk-in and urgent care. So that is something that we find that it's still people are not used to the urgent care concept. And this is something that we're open every single day. Form A is open every day.
And the other thing is that, especially your patients, right? So Dr. Midelton's patients, let's say you can't get in to see him. It doesn't mean you go to the emergency room. You should come right here to the urgent care because Dr. Midelton is working hand in hand with the providers in the urgent care so he can still oversee your care.
And then I get the note, I get all the labs, I know everything that happens.
Exactly. So just because you're not seeing him, you are seeing him through somebody else.
Yeah.
So
that was something that I was telling one of your patients because they come in and they want to see you. But if they can't see you, I said, he's the medical director. He's actually working with the other providers here very closely. And if the provider felt that they needed to consult with you, you're there.
Right.
Yes,
So
and I walk in on occasion anyway if it's
Right.
complicated or they're not sure.
So we are encouraging you to, because I know a lot of your patients are listening to us because we're on Form A and we have a lot of followers. So we want to make sure that you understand, that you understand how important it is that you do not go to the emergency room. You come here. We're open every day. Dr. Midelton has access to all your notes. They can consult with Dr. Midelton. So just make sure you come here. And we're open until 8 o'clock. So, we are accessible to you. And even if you need stitches, we do stitches, we are able to.
Asthma.
Asthma. Before we go, we're going to go diabetes. This is a major issue. If you are a diabetic, you should be going to see which doctors frequently?
Your internist.
Your internist. It should be at least every 3 months.
About every 3 months, and then there's once a year screening for diabetic retinopathy and neuropathy with of your feet with the podiatrist and the ophthalmologist. Those are usually once a year.
And we have a podiatrist here too, so you can see them here. And we work with amazing community partners, all of the specialists that help us. So it's coming to an end of our show. We first want to thank you because I know you had a long day, and then we asked you to join us, and I know that you had emergencies, so thank you for joining us and for
My
doing.
pleasure.
You do an amazing work with the community. Yes. I know that you're loved. Everywhere we go, they know Gary.
Yeah, Dr. Gary.
Dr. Gary. So Dr. Gary, thank you. We'll have you back because we'll talk about other subjects that are important to you because we are here for you.
Yep. Don't forget to like us.
Goodbye. Bye.